My name is Peter Lawrence, and I'm pleased to present 5 outstanding papers from the January issue of the Journal of Vascular Surgery, Venous and Lymphatic Disorders, which are freely available for the next 2 months. The CME article for this issue is called A Randomized Controlled Non-Inferiority Trial Comparing Radiofrequency with Stripping and Chiva Technique for Insufficiency of the Great Saphenous Vein by Kennis and co-authors. This study assessed whether radiofrequency ablation was non-inferior to stripping and Chiva methods of treating saphenous incompetence at 2 years. From 2012 to 2015, 225 limbs were randomized to radiofrequency ablation, high ligation and stripping, or the Chiva procedure. No differences in postoperative complications or pain were observed between the groups. Radiofrequency ablation was found to be non-inferior to stripping and Chiva at 24 months. However, Chiva did have a higher varicose vein recurrence at 24 months in this study. Our next article in the editor's choice is Classification and Treatment of Endothermal Heat-Induced Thrombosis Recommendations from the American Venous Forum and the Society for Vascular Surgery by Kabnick and co-authors. These societies developed a single guideline for the management of EHIT, or endothermal heat-induced thrombosis. The guidelines are divided into the classification of EHIT, risk factors and prevention, and the treatment of EHIT. One major feature is standardization to one classification system, which allows continued analysis of the 2 older systems while standardizing reporting for new research using this new system. Treatment guidelines are tailored to the AVF EHIT classifications of 1, 2, 3, and 4, and references made to the use of surveillance, antiplatelet, and anticoagulants, including direct oral anticoagulates in each category of EHIT. Lastly, EHIT management as it relates to the great and small saphenous veins is discussed. The next article by Kim et al. Is called Results of Polidocanol Endovenous Foam in Clinical Practice, or PEM. PEM was used to treat superficial reflux in 60 patients. SEEP distribution was SEEP 2 in 32, SEEP 3 in 14, SEEP 4 in 10, and SEEP 5 in 4 patients. The average pre-treatment venous clinical severity score was 7.3, and saphenous vein diameter was 6.5 millimeters, with the average length of the vein treated at 31 centimeters. The average volume of the PEM used to treat saphenous veins was 9.3 cc's. Closure rate at 3 months was 93%, and also at 6 months it was the same at 93%. And the venous clinical severity score increased or improved from 7.3 to 1.4. Complications included 1 deep vein thrombosis, 5 patients with superficial thrombophlebitis, and 4 patients with skin pigmentation. The authors concluded that early closure rates using the PEM technique are maintained at 6 months and are comparable to the results reported with non-thermal non-tumescent and with thermal tumescent technologies. The next paper highlighted this month is Randomized Clinical Trial of Radiofrequency-Induced Thermotherapy combined with TIP, or transilluminated power phlebectomy, versus high ligation and stripping for the treatment of lower limb varicose veins by Liao and colleagues. They evaluated the efficacy and safety of radiofrequency-induced thermotherapy combined with transilluminated power phlebectomy in the treatment of lower limb varicose veins. In comparison with high ligation and stripping combined with TIP, the total closure rate of the great saphenous vein at 12 months was slightly lower with the RFITT than with the high ligation group at 90.1% versus 97%. But this was not statistically significant. Operation time, intraoperative blood loss, duration in the hospital, duration in the bed, and resumption of activities was slightly better with the RFITT approach than it was with high ligation and stripping. There were no differences in DVT, phlebitis, hematoma, pain, and infection, but skin pigmentation and paresthesia were slightly better with the radiofrequency TT than with high ligation. At 12 months, both groups showed similar improvement in the venous clinical severity scores. The final article highlighted in this issue is Clinico-Radiologic Predictors of Sclerotherapy Response in Low-Flow Vascular Malformations by Baga and co-authors. They evaluated the effectiveness of sclerotherapy agents in low-flow vascular malformations to predict response. Symptomatic low-flow vascular malformation patients were subdivided into venous malformations and lymphatic malformations. Cavitary, which was in 43%, and spongy, which was in 38%, were the most common phlebographic patterns. Sodium tetradecyl sulfate and bleomycin were the most commonly used sclerosants in the VM and LM respectively. The mean number of sessions was 4.35 for vascular malformations and 2.64 for the lymphatic malformations. Among the vascular malformations, 51% had an excellent response to treatment and 76% had an acceptable response. All patients with lymphatic malformations had an acceptable response. The cystic component on sonography and a direct draining vein were seen more often in the excellent responders, in addition to the absence of disfigurement, discoloration, and diffuse involvement. The best model for predicting excellent response was a direct draining vein and the absence of skin discoloration. Thank you for watching. For more information, please follow us on social media and remember to like, comment, and share. We hope you enjoy these highlighted papers and the other excellent papers in this month's Journal of Vascular Surgery, Venous and Lymphatic Disorders. Remember that these articles are free to read until the end of February. And thanks for your attention.